Scheuermann's disease, as I have said earlier, the apophyses are not well developed. There is retardation in the growth of the apophysis, and occasionally you may get anterior herniation of the discs, producing a gouged out defect in the superior anterior margin of the vertebral bodies. That also represents small node. And then we will come to the entity called metabolic bone disease, either due to hypovitaminosis or hypervitaminosis, minerals, calcium, phosphorus, aluminum, metals, iron, mercury, etc., hormones, enzymes, and muscles also play some part in the mineralization and ossification of bones. The most common, not very common, but most common in tropical countries and underdeveloped countries is rickets in children. This is due to deficiency of vitamin D and calcium. And you see cupping of the anterior ends of the ribs and also proximal ends of the humeri. Radiological characteristics, cupping of metaphyses, not only tubular bones, other bones also. Deformities of bones, because these are soft bones. That's why even if the child does normal routine walking and running, you may get deformities of bones. Frontal bossing, or the so-called craniotabes, rachitic rosary. Because there is lack of calcium, the bone is not mineralized properly, as though to compensate for that, excessive osteoid is noted. That's why rosary type of bead, technically you can find fractures easily, and eventually, if neglected, secondary hyperparathyroidism may take place. Here again, another case of scurvy. It's not rickets. Often people mistake scurvy, and differentiation between scurvy and rickets is rather difficult, but it's not that difficult, because in scurvy it is osteoporosis, whereas in rickets it is osteomalacia, softening of the bones. Here they are brittle bones. Not only that, if you look at the cortex of the epiphysis, there is a thin line of cortex of the epiphysis. Look at the epiphysis for the proximal ends of the humeri. They are almost phantom type epiphysis, but still cortical outline is noted. And ribs also, anterior widening. In this condition also you can get anterior widening. And osteoporosis is a loose term in the sense looseness of the bones, osteopenia. But when the lack of protein is there, you call it osteoporosis. Whereas if the lack of mineral is there, generally you call it osteomalacia. But occasionally, most of them coexist. Endocrine causes of osteoporosis, Cushing, Turner's, and women, diabetes, hyperparathyroidism, hypopituitarism, hypothyroidism, namely creatine, myxedema, hypogonadism. In all these conditions, you may get generalized osteoporosis. Cushing syndrome, what are the things that occur? Delayed bone maturation, osteoporosis, pathological fractures, even if there's trivial trauma, they get fractures, particularly compression of the vertebral bodies, and excessive callus, hypercallosis they call it, osteonecrosis, particularly in the heads of the humeri, heads of femora, infarcts, and because of the immunity is decreased, you may get septic arthritis or infections of the joints. Vertebra plana, look at the osteoporosis and marked compression, wafer-like vertebra in Cushing's. In the first look, it appears the radiograph shows multiple nodules in the lungs, but these are all healed fractures of the ribs with callus. This is bilateral, symmetrical. Again, vertebral bodies in the APU and lateral U. Look at the compression of one of the upper thoracic vertebrae in the spine, and look at the sclerosis. That is what I was talking about, pseudocallus or hypercallosis. In normal traumatic fractures, you don't get that kind of callus in the superior margin. Again, another case of Cushing syndrome, multiple fractures bilaterally. some mediastinal fat because of the corticosteroids. Vertebral body, lateral view of the thoracic spine, so-called fish mouth vertebra or fish type of vertebra, biconcave type of vertebrae with a depression. In these cases, you may see sometimes a sclerotic margin due to hyperkallosis, which I was talking about. Look at the osteoporosis, only thin line of cortex, and spongiosa is almost nil. There is what is called marked differentiation between the spongiosa and the cortex. Quite reverse of osteomalacia, where there is a ground glass appearance. You cannot make a difference between the cortex and spongiosa. In a cretin, flat vertebrae with the anterior beaking, earlier I have mentioned. But that beaking and flat vertebrae you can get in other conditions also. But clinically you have to establish that is the cretin, and these are the changes in the vertebral bodies. Of course, delayed ossification centers are there in the growing bones. Acromegaly, it is rather rare, but few American radiologists, my colleagues, have observed in a chest film marked hypertrophy of the first ribs. It may not be constant, but in some of the cases, an PA view of the chest, if you find these, think of acromegaly. Hyperparathyroidism, either primary or secondary, marks resorption of the bones. That's why you get clavicles fractured, resorption of the lateral ends of the clavicles. They should not be mistaken for pycnodysostoses or craniocleidodysostosis. This is due to partial resorption of the lateral ends of the clavicles, but the medial ends of the clavicles also resorbed. Now we come to the important entity, infections of bones. Namely the ribs, for example, the PA with the chest, we will say, looks like a coin lesion in the right apex. But actually, if you take another view, that rib is destroyed, that third rib is destroyed, and there is a soft tissue swelling reflecting. This is, in an infective case, it is a tuberculosis of the rib. Another, in a female, apart from the breast and cystic changes, you find a soft tissue swelling in the costochondral junction with central lucency in the soft tissue swelling due to caseation necrosis. It is proved to be TB. Classical kyphosis of the thoracic spine, the bilateral paravertebral swelling in a child due to classical tuberculosis of the spine. If there is paraplegia or other neurological symptoms, you call it Pott's paraplegia. But in this particular case, there is no paraplegia yet. Even in tuberculosis of the spine, there is what is called multicentric type of tuberculosis. Look at this. Some of the pedicle, some of the vertebral bodies, some of the ribs are destroyed, proved to be multicentric tuberculosis. It is an unusual case. It looks as if it is a herniation of the disc anteriorly, but reactive sclerosis is there on either side. Still, it doesn't help us in the differential diagnosis, but on further examination of CT, there is a paravertebral soft tissue swelling proved to be tuberculosis of the spine. I'm just showing you the variety, the spectrum of tuberculosis of the spine. On CT, of course, we find lytic area. In the one on your right side, there is a small lytic area in the pedicle. You may think of metastasis, but this is tuberculosis. Tuberculosis of the vertebrae, look at the small paravertebral soft tissue swelling on CT on the left side. In a case like this, the first impression is maybe there is a pneumonia, but if you look carefully, the ribs, underlying ribs or overlying ribs are sclerosed and irregular. And there may be a little pleural reaction also. The triad, namely pleural thickening, pneumonitis, and bone changes, particularly in the ribs, sclerotic changes, all three indicate a fungal infection, most commonly actinomycosis. One on your right side is the same patient in a lateral view. One on your left side is another case of actinomycosis involving the vertebrae with a unilateral paravertebral soft tissue swelling on the left side. Multiple vertebrae, all of them are sclerotic, indicating fungal infection such as actinomycosis. Caffey's disease. infantile cortical hypostosis. On a PA view of the chest alone, usually these children come with slight elevation of the fever, temperature with fever, leukocytosis, irritability, and you take a radiograph of the chest, lo and behold, you find some changes in the clavicles, bilateral, it may be unilateral also. Fortunately, if the mandible is included in the film, you may get hypostosis there also. This is what is called infantile cortical hypostosis, the etiology of which is not known, may be of viral origin. With corticosteroid therapy, these will disappear, resolve. A lytic area in the pedicle extending to the transverse process. There is no soft tissue swelling, significant soft tissue swelling. This proved to be eosinophilic granuloma, not a tuberculosis. Hematological, sickle cell anemia, thalassemia, both of these are not uncommon in our country. Look at the ribs, cone view of the ribs. A rib within a rib, striated appearance, classical of sickle cell. And of course, the so-called fish type of vertebra, which we mentioned earlier in Cushing syndrome. Here there is not that much of osteoporosis. On the other hand, there is sclerosis, the so-called Raynaud's phenomenon, that is notching of the inferior and superior vertebral end plates, classical of sickle cell anemia. Central vertebral depression, or so-called H vertebrae. This is classically described in sickle cell anemia, uremic osteodystrophy. You can also get so-called sandwich type of vertebrae. Gaucher's disease, homocystinuria, there is a lot of osteoporosis with H type of vertebrae. Hereditary spherocytosis, rare. Thalassemia also you may get, but sickle thal is more common than in pure thalassemia. And occasionally mild bowing, Cupid's bow they call it, you may see in normal children or adults also. Thalassemia, hypermedullinosis, the widened ribs. Another thalassemia in failure, marked anemia, and bilateral pulmonary edema. Occasionally you may get infections, pneumonias also in the lungs, but they are more common in sickle cell disease with infarcts and superimposed pneumonias in the lungs. Cone view of the left ribs. Look at that bulged anterior ends of the ribs. These are due to hypermedullosis, as though to compensate for the normal hematopoiesis, and you see this bulb-like ends. Generalized decrease in bone density, acquired. Earlier we said lucent lesions, osteogenesis imperfecta and all that. This is acquired. Osteoporosis, either senile or postmenopausal or immobilization, whatever causes. Osteomalacia due to deficiency of vitamin D, calcium, and sun rays. Hyperparathyroidism, either primary or secondary. Cushing's, leukemia, lymphoma, myeloma, and metastasis. These are the things that you have to think of. Osteoporosis, another metabolic disorder, alkaptonuria. Homogenetic acid, homogenetic oxidase is decreased, producing malacetoacetic acid. Difficult to pronounce, isn't it? And because of this, you get chondrocalcinosis. It is not only calcification of the disc material, superimposed degenerative change of spine, but osteoporosis. That is typical of ochronosis. Ochronosis because when you see the urine, it is ochre in color, brown in color. Now we come to the neurofibromatosis, confined to the spine. Other changes may be there because it is a systemic disorder. Kyphoscoliosis, vertebral scalloping, most commonly posterior, but you may get anterior or even lateral if there are lateral. Meningoceles, agenesis or hypoplastic pedicles in the spine. Posterior vertebral scalloping could be physiological, particularly in children. Increased intraspinal pressure, either due to tumor, syringohydromyelia, or uncontrolled communicating hydrocephalus. In neurofibromatosis, it is mostly due to dural ectasia. In Marfan syndrome and Ehlers-Danlos syndrome also, you can get posterior vertebral scalloping. In the thoracic vertebrae, acromegaly, dwarf syndromes, namely achondroplasia, mucopolysaccharidosis, etc. Ehlers-Danlos syndrome, Marfan syndrome, neurofibromatosis, which we have mentioned already. The one on the left side is gigantism or acromegaly, whereas on your right side it is neurofibromatosis. Look at the posterior scalloping and widening of the spinal canal, dural ectasia. And then ivory vertebrae, a dense vertebra isolated to one vertebra called the ivory vertebra. Paget disease, you can get it. Sclerotic metastasis, you can get it. And tuberous sclerosis, you can get it. Sclerosing hemangioma, you can get it. But here, if you look carefully, the vertebra is bigger, brighter as compared to the rest of the vertebrae, adjacent vertebrae. And it proved to be Paget disease, monostotic in this particular case. Similarly, in the clavicles also, particularly in the left clavicle, expansion, lytic area with a fracture. Paget disease has got three phases: lytic, sclerotic, and mixed. This is the lytic phase. Sclerotic phase, look at the right clavicle, bigger, brighter, and the process goes all the way to the articular margin. That is important finding in Paget disease. And because of the softening, you get bowing of the clavicle. And then benign generalized osteous neoplasms that reflect upon the thoracic cage. Chondromata or exostosis, osteochondromata, you may see those. Chondroma of the rib, look at the cone view, dense, calcified. From the calcifications, you know it is a cartilaginous tumor, and it is well circumscribed. It is a chondroma. In a PA view of the chest, it looks as if it is a coin lesion, but cone view shows it is arising from the rib. A rare case, one on your left side, involving the vertebra expanding. It could be an aneurysmal bone cyst. Occasionally, desmoplastic fibroma may produce that. One on your right side, classical, just below the pedicle, classical finding of osteoid osteoma, central calcification, surrounded by lucency, surrounded by reactive sclerosis. Something like a target sign, osteoid osteoma. Now we come to marrow disorders. Earlier, hemopoietic disorders we have discussed. Now, malignant marrow disorders, leukemia, lymphoma, myeloma. Leukemia in children produces osteopenia plus multiple compression fractures. Lymphoma, again, also you may get an ivory type of vertebra if it involves only one vertebra. That's what it is here. But then how do you differentiate from Paget disease? It's not enlarging. It's not bigger than the rest of them. Now, differential diagnosis of ivory type of vertebra, metastases, closing type of metastasis such as occurs in prostate, lymphoma, Paget disease, osteosarcoma, primary osteosarcoma of the bone, or even metastases, chronic osteomyelitis, Gary's type of osteomyelitis, malriostosis, chordoma. Generally, it produces a lytic area, but it may produce ivory type of vertebra. Myeloma, which we have mentioned, so-called Poem syndrome. You can get sclerosis of the bones, and of course, osteoblastoma. Myeloma, expanding lesion of the lateral end of the right clavicle. Of course, other lesions or lytic lesions are also there. It is a case of multiple myeloma. Isolated to the sternum, plasmacytoma. Benign tumors of the sternum are rare, whereas malignant tumors, metastases, chondrosarcoma, plasmacytoma, Hodgkin's, these are common in the sternum. This is proved to be isolated plasmacytoma. Multiple myeloma again, multiple fractures of the ribs. Always we say, generally, the pedicle is preserved in myeloma, as you see in the left pedicle of the compressed vertebrae. Whereas in metastases, that's the first one to be involved. But when the entire vertebra is involved, it doesn't make any difference whether pedicle is involved or not. It has to be either myeloma or metastasis. There is no differentiation. Hemivertebra on the left side simulating vertebra plana or wedged vertebra, whereas lymphoma, compressed vertebra, vertebra plana on your right side. Metastases, mostly osteosclerotic from carcinoma of the prostate, And remember the so-called pedicle sign. Look at that 11, 10, 9, 8th vertebra. The pedicles are gone. Metastasis from the carcinoma of the lung. Again, pedicle is gone, not much of soft tissue. So far we have mentioned the bony thoracic cage, mostly. I didn't mention about the soft tissues because cage means strong bars, and thoracic cage, including the ribs, clavicles, sternum, and vertebrae. I haven't included the scapula. So I hope you have understood the various pathologies that involve the bones of the thoracic cage, and there should not be any confusion about it.